this person has essentially no leg pain, maybe a little bit of buttock pain at times, but is active, is fit, not overweight, and has a normal neurological examination, and comes for advice. Takes non-steroidal medications occasionally, but overall is functioning well. Has not missed a day of work from this, and just was concerned because they were told that they needed spine surgery. So this is their X-ray, and I do have an MRI scan. Anybody want to take a crack at this? Anybody? This is a complex one. We can jump up to the professor, but I wanted to see if anybody wanted to describe this. All right, John, it's all yours.
Well, the obvious finding there is a grade 2 spondylolisthesis as per your chart below. It looks like there is also, and you have control of the pointer, so you can show it. It also appears to be a pars defect. I can't tell on just this one view if it's unilateral or bilateral. With this degree of slippage, I would suspect that it's bilateral, but it looks like it's been there a long time because the edges are well formed, rounded, and not something that would be consistent with an acute fracture. What I would do at this point, obviously, is history and physical examination to find out neurological issues and neuro exam, and you already told me that was all normal, essentially. So then the next step to figure out is this unstable? Is this acute? Is this something that needs to be done or something that can be done? So the first thing I would get is flexion extension views to see if there's any acute instability there. And then I absolutely agree with an MRI to check out the neurological structures, but also I'd get a CT with reformatted images. It's quite possible that this is already fused in that position and it's a stable spondylolisthesis, and a CT would give you much better information regarding that as opposed to an MRI. Those are my preliminary thoughts.
Excellent. Yeah, and the only thing I'd add is this almost looks like a calcification across this bridge here. That's what I initially thought.
That's
right here.
right. Well, hence the CT requirement.
Yeah. All right. So she came to me with an MRI scan, and she is getting further workup. Here's the MRI scan. So I'll play the sagittal first. I'll leave the midline just for a second for your viewing pleasure, and then we'll go off to the sides. Number of juicy findings on this. Any students want to take a crack? This is a sagittal view. I think there's a really good view here of foraminal compression. Anybody? Everybody's quiet today. No socks going out.
Morning.
No socks.
Morning, Dr. McLaughlin.
Hi, Chris. How you doing?
Good. How are yourself?
Good. What do you think?
Would that be like an S2 foramina?
Nope. First of all, this is whenever you have a spondylolisthesis, remember the higher root. So remember, you have a disc herniation L4-5. Almost always the nerve root that's compressed is the 5 root. Okay. But if you have an L4 spondylolisthesis, most likely the L4 root's going to get compressed because it's foraminal compression.
Oh, okay. Okay.
And or stretching.
And or stretching, right. So here's a beautiful sagittal image. Look at every one of these foramina here. You see the nerve root. You see a little cuff of fat around the nerve root, cuff of fat, nerve root, cuff of fat. There's the pedicle above. Okay. So that, remember, the neural foramen is bounded by the pedicle below right here. Can you guys see my pointer? Okay. Pedicle above, the disc in front, and the facet joint in back. This is a perfect neural foramen. But where's the L5 neural foramen? Gone.
Can't see it.
Completely obliterated, right?
Sometimes you have to go a little more lateral for L5S1 because it is a little more lateral, but you can see it a little bit there. But your point is obviously well taken. All the other ones are pristine.
And then we'll go to the other side. Chris, and we'll go, and then I'll go midline, and you can describe what you see midline. So we're going to the other side now. MRI scans. Go ahead.
How often are these just like completely asymptomatic with this degree of slippage?
My experience is they're rarely are they totally asymptomatic, but there are people that come in with mild or moderate back pain or a long history of back pain, oftentimes as a, even as a child, but they never got anything checked out and they're functional. What about you, John?
Well, they've done studies on like Army recruits and people who they can mandate get X-rays, and even in completely asymptomatic people, even in their 20s, you're going to have somewhere between a 10 and 20% incidence of L5S1 spondylolysis / spondylolisthesis that is completely asymptomatic. So it's something, just because you see it doesn't mean you have to operate on it. A lot of times these can be stable, long-standing, and very commonly seen. So that's why you just don't operate on X-rays. You have to get the entire history and exam.
Chris, tell me what you see on this scan. Oh, Nilay's got a question. Hold on. Go ahead, Nilay.
Yeah, so I was just going to ask, like, yeah, just like Dr. Tydings said, just because it might show up doesn't necessarily mean it's something you need to be operated on. But I was just curious, how much of a risk does this patient have of like a Cauda-Equina syndrome or even conus medullaris syndrome, where it would become a neurosurgical emergency?
Well, that's great. Apropos of the sagittal image here. Take a look, Chris. Tell me what you see.
Well, I'm not exactly sure what the intense region within the L5 and S1 vertebrae is.
Okay.
I know
you're talking about these signal changes within the vertebral body?
Yes.
Okay.
And then more posterior to that, there's the hyperintense region right past the vertebrae there.
Yep.
So
what would you say about the spinal canal?
Is it
stenotic?
I wouldn't classify that as stenotic from other scans that
I agree. I think it's open.
Yeah, it looks pretty open. So
I would use widely patent.
Widely patent.
Yeah, got it.
Especially above L4-5, there is no evidence of any stenosis, Cauda-Equina, conus issue whatsoever. The only question to ask is, could you have an acute problem? But that would depend upon this is a stable or unstable spondylolisthesis.
Yeah. So, Nalay, to your point, and this gal has been, this man has been blessed with a very large spinal canal, which some people have. There's standard deviations of spinal canal, but this is a very open spinal canal. And Chris, you pointed out some changes here. And this hyper intense area. I'm not really sure what this is. Look at the other normal discs, completely normal, and then we come down here. So these changes have an eponym they're called modic changes. They were described by a radiologist in Cleveland Clinic, Michael Modic. I love eponyms. They show a finer level of detail on studying. So these are modic changes. They're end plates. It's basically end plate sclerosis that occurs from like continued microtrauma to the area. And again, on the X-ray, as we saw, this is very dark. So remember, on an MRI scan, especially a T2 weighted image, something dark has no water in it. And this to me looks like an osteophyte right here that's formed. So I think this woman's body has probably done the fusion.
Beat us to it.
So you have the sagittal images. I'm sorry, the axial images. All right, so a couple of little things. So spinal canal here. Daniel, what's this structure right here? Got to know the structures all around too, right? You got one on each side, one there and one there.
Kidney.
There you go. Good job. Here's our cauda equina, nice patent canal. Widely open here. So you're seeing totally open spinal canal. And Neely, I'd say her chances of a cauda equina are very low, unless, as Dr. Tydings mentioned, she had some kind of instability there. The canal's open everywhere. So she needs further workup, as you pointed out, John. I sent her, I think Jason's on, I think I keep saying her, it's him. Sent them for a CAT scan and some flexion extensions, but based upon the complaints, I have a low threshold. I did speak with the patient about, the fact that this would be a big operation to try and decompress those two foramina and put screws in at the 5 and the 1 level, and that I wasn't optimistic that we could eliminate back pain with that procedure based upon the chronicity of it and the level of pain. So probably going to leave this alone. I don't think we have any other pictures, do we, Maggie?
No.
Okay. Any other questions on this? Grade 2, bordering on grade 3 spondylolisthesis.